Hi, everybody. Thank you for joining in on our webinar today. We're going to talk about pre and post anesthetic care and considerations of pediatric patients. Just to let you know, the webinar is being recorded today. And so then it'll be able to be shared at the end of today as well for your staff. Just while we get started, it would be helpful if we knew who is all here. So if you wanted to just put into the chat your role and then even maybe which location you're at, just so we can see who's all here today. My name is Alicia Hayes. I'm the interprofessional education specialist here at SickKids, working with the Community Surgical Partnerships Program. Also with me, I have Jessica Tang. She's the interprofessional education specialist for the preoperative unit, the PACU, the pre-anesthesia clinic, and the sedation team here at SickKids. Jessica started working at SickKids 7 years ago in those same areas, and she's worked as an educator for the last 2 years. Jessica also provides education around the hospital for pre and post procedural care in pediatric nursing orientation. She also runs an interprofessional sedation workshop 3 times a year and provides general anesthesia and airway education and training for RNs working in the PACU recovery area. She also does some off-site anesthesia recoveries for SickKids patients in other hospitals such as Toronto Western and Sunnybrook. So Jessica has a wealth of information on the topic that we're going to have today. So there'll be an opportunity for questions as well as to provide some of your input as well today. So just taking a moment, we can see that we have some professional practice nurses. We have an RN student. We also have an educator and some RNs. Perfect. Great. Okay. Thank you for joining in. So we will leave the chat open today as well too, so that we have it available to ask questions. But just to give a little bit of a disclaimer while we start, also because today will be recorded, so some people might view it at a later date, that the education today is not intended to be a complete or a current statement of the subject matter. It's current as of today. We ask you to use this at your own risk, as well as that you're responsible for confirming the accuracy and completeness of all information in today, as well as how it will relate to your setting as well too. So just a little quick disclaimer. Again, thank you for adding into the chat where you are located as well. Perfect. So just a few guidelines. If you've never taken a webinar with Connected Care, we just ask that when you're not speaking, if you can unmute at any point. If you have any questions, you can also use the chat at any point. Feel free to turn your video on for a more engaging experience. We also encourage participation, so feel free to ask questions, join in as you would like. And then again, I also understand if your internet connection is low, or maybe if you're in the shared office, if you'd like to keep your video off, that's understandable as well. So today we're going to cover a few topics, and so we're hoping to discuss key considerations of working with pediatric populations. We're going to review developmental milestones as they relate to pre and post anesthetic care of pediatrics. We're also going to discuss family-centered care approaches for working with children and their families. We're going to review pre-anesthetic considerations when working with pediatrics, and we're going to review common post-anesthetic complications. Perfect. Okay, so to start us off, one thing when you're preparing for working with pediatrics, it is also important to think about that pediatrics are not just little adults, and that the right equipment and the right assessments matter. So it's important to ensure that you have equipment that's designed for pediatrics and designed for their age, weight, and size. The wrong equipment and the wrong assessments can lead to errors, such as errors in medication doses, the way that we interpret vital signs, and then lead to potential injury or harm. So some of the examples of pediatric-specific equipment that is helpful is a pediatric emergency code cart, so having one dedicated to just the use of pediatrics so that you know all the emergency equipment is right there. It includes the appropriate size backboard, the appropriate measuring chart or tape, for lengths and doses, also a cardiac defibrillator that's designed for pediatric use. It's also helpful to have pediatric scales. So for example, that you could have an infant scale to get accurate weight. Also, sometimes diaper scales are helpful. So if you're looking at measuring urine output, that's a way that you can measure for a child that's not toilet trained yet. Also having a scale probably similar to what you would have in adult care, a standing scale so that you can accurately measure the weight of a child as well. We also want to think of from a vital sign perspective. There's often different sizes compared to adults when we are thinking of pediatrics. So thinking about different size blood pressure cuffs, different ways that we can take a temperature. For example, are we going to use a thermometer for auxiliary? Are we going to do temporal or oral or tympanic? So thinking about the best way that we can do it, knowing that oral is not always the way that we can do it. We also want to think about, do we have probes that we can add that we want to be able to put on their finger, we want to put it on their foot, we want to put it on their toe, things like that. So we can have a little bit of different type of supplies. Then also thinking of from an infusion pump. So it's recommended for fluids and medications to be delivered by a programmable pump, either large volume or syringe for pediatrics. It's not often best practice to use gravity, unlike which we know is better practice or more common practice for adults. We also want to think about family-centered care. So this is probably something that's incorporated into adult care, but we really think about it from a pediatric perspective because we know that often a child doesn't come to the hospital or come to an appointment alone. So the child's at the center of the care, whereas the family is a very important part of the care plan as well. Family-centered care does not mean that the family directs the care. It's just that they're partners in the plan of care. We know the family caregiver or their guardian is an integral partner in their care. They're experts in their child's care. They're a great resource when you're gathering history or assessments or developing a plan of care. So we just want to highlight that some of the things that we'll talk about are ways that we can include the family caregiver as well as the child into conversations. This slide is not designed for you to memorize it. It is just to show that depending on the age, vital signs can change differently for pediatrics opposed to adults. If you are looking for more information on a health assessment of a pediatric patient, you can look at the Connected Care website, which we've shared with most of your hospitals, and we can continue to share at the end of the session, where you can look at pediatric health assessment webinar that goes into this in more detail as well. But this is to look at that there's general ranges for pediatrics. The age, clinical illness, and the activity can alter these. So it's really helpful when we're looking at pediatric vital signs that we want to do the least invasive method first to just minimize the impact on the rest of our vital signs. It can also be helpful knowing that there are all these ranges to have a vital sign reference card available for you or available for your staff, just so that it's an easy reference to look at so that you don't have to memorize it. Just because then we know that sometimes there can be errors in memorization. So just having it available so that you can take a quick look at what the age is, what you expect the heart rate or respiratory rate to be, so that you can have a guideline. Also, I just want to highlight from a temperature perspective, a lot of different resources or literature will say different measurements for what a fever is, and it can change depending on their clinical picture. So also referring to what your hospital also will refer to as a fever. Okay. We're going to go into some pre-op or pre-anesthetic questions. So sometimes this pre-op assessment will be done in advance, for example, virtually or over the phone. And then some of this can be done the day of the procedure. Really, the goal of a pre-op assessment or screening is to optimize the child for the surgery or the procedure. The more information that you can gather, the better, and it'll allow you and the rest of your nursing staff to be able to prepare, as well as give the family an opportunity to ask questions and to better understand what they're expecting. This will look different at each of your sites, but just some of the topics that is encouraged to be in there. For example, what's their current health status and their NPO status? So just confirming on the day of the surgery that they're not sick, Have they had any recent infections, any antibiotic use or inhaler use? Have they been prescribed antibiotics? Because that can impact their airway. So for example, children who were recently prescribed antibiotics may still have a reactive airway, and some anesthesiologists might like to defer this procedure or surgery for 6 weeks post-antibiotic use. So that's something to think about if a child or their family disclose their health status. It's also important to confirm that they've actually fasted for this procedure, similar to adults, but we'll go kind of into our guidelines, knowing that sometimes it's not easy to just say not eating after midnight or not eating after midnight like with adults. So we'll talk about some of the recommended NPO guidelines. Some other things to think about are potential barriers to communication. So what is the family or child's primary language? Do they need an interpreter? Is there any sensory impairment, such as visual or hearing, for both the child or for the caregivers? Are there any caregiver developmental delays, or do they learn a little bit differently? Because you're going to provide them with some discharge teaching. So you want to make sure that you have it set up as best as you can from a pre-op perspective. You also want to look at allergies. Have they had any previous reactions to any anesthetic or medications? Also thinking about, are they on any medications? Did they take any medications that morning, or were they recommended to not take anything that day? Again, highlighting like their NPO status, what did they take that morning? And you want to ask about all their prescriptions, whether they're over the counter as well as herbal or nutritional supplements, because sometimes those are missed or forgotten to just disclose. It also can be really helpful to think about their previous surgical or hospitalization history. So can we document any previous anesthesia history as well as the family histories, especially if the child has never gone under anesthetic before or had any procedures? Sometimes a family history can be quite helpful. Also, is there any implanted devices that could impact, or again, have there been any complications when they've been hospitalized previously? It's important to find out because this can actually help with pre-op anxiety, which can impact post-anesthetic anxiety, which we'll talk about some of those complications as well. So we want to just think about what their past history has been so that we can make sure it's the best environment for this procedure. Again, doing a full medical history, thinking about recent exposures, looking at from an anesthetic risk, what's their ENT or ear, nose, and throat history? Do they have a difficulty swallowing or any airway abnormalities? Do they have a respiratory history? Do they have exposure to secondhand smoke or chronic respiratory illness? Like, do they use inhalers at home or any nebulizer treatments at home? Because sometimes they might forget. Families, they're not hiding the information, but it might be forgotten to disclose. Also, is there any neurological history or endocrine history, such as diabetes, that could impact maybe their NPO status or their recommendations to stay at home in a pre-op perspective? Also thinking about, because of the risk is anesthetic or surgery on pregnancy, it can be recommended for patients assigned female at birth and is 12 years of age, or if they're under 12 but have had their period and they have the potential for pregnancy, such as both having their uterus as well as functional ovaries, it may be appropriate to ask for consent for a pre-procedural pregnancy test, either with urine or blood testing. Just a quick question in the chat. Can you describe best practice regarding administering versus preoperatively? Should they be placed in a... Perfect. We will touch on some of this information as well too. But thank you for that question. We will look into that question. We will get to your question as well. Maybe we can chat about that right before pre-op. Okay, so we'll keep going through this part and then we will get to your question. Thank you for asking it. Other things to think about from a pre-op perspective are just thinking about, is there any psychological developmental history? Is there any psychosocial or family status as well? That's really important. From an NPO guideline, so here's some recommended thoughts. I know some hospitals will do it differently or will have like a lengthened fasting period. Thinking about clear liquids, which can be different. People can interpret clear liquids differently. It's really thought about that you want to be able to see through the liquid. So things like water or apple juice, but things such as like Jello or a gelatin dessert aren't technically a clear fluid. It's also important to think about, like, can the person have gum before, or like mints, because that can still increase gastric contents. So some hospitals will still say no to those as well. So really important that you go over this with the family, or whoever at your hospital does this pre-op assessment. Is really important to highlight these and the risk that if the guidelines aren't followed, that there is potential for their procedure to be canceled because of the risk of aspiration if they're not NPO. Things to think about that are a little bit different with pediatrics, and depending on the pediatrics that will come to your hospital, is ages. So sometimes it's not realistic to say that the infant is going to go 12 hours without anything. So then thinking about whether they're breastfeeding or infant formula, or again, needing to have a little bit of water or juice in the morning when they wake up, but not a breakfast. Depending on their eating schedule or clinical situation. So for example, if they're diabetic, it might not be realistic that they stay at home for the pre-op and they're admitted. One important caveat to this is talking to the family about when they should eat as well. And when it's not encouraged that the family also becomes NPO with the child. It can be a long day. It can be anxious for family members as well. So we do encourage that they eat breakfast or they eat while their child's in procedure to limit their own individual risk. Pre-op anxiety is obviously something that you want to avoid, but the reasons that a child might experience anxiety is not limited to this list. And it's actually can be helpful to just think that every child that comes in is going to have some baseline level of worry or anxiety coming into the hospital. We know it's not a super fun area. We try to make it as calming as possible, but thinking if we kind of treat every child as having anxiety, then we can kind of make the situation a little bit easier. So risk factors can include developmental history. Have they had any physical harm or injury? They're separated from their parents or caregivers at times, which can be anxiety provoking. Also, just generally the fear of unknown or the fear of uncertainty in the hospital, their fear of loss of control. And if they've had any other negative experiences, it can be really hard and can promote anxiety. So worry and anxiety can be mitigated with strategies such as using family-centered care, understanding their growth and development, appropriate language. And then again, we're going to kind of talk about some medications or strategies that you can use as well. So maybe we can, do you want to touch base on medication use as well?
Yeah, sure thing. I feel like in different organizations, you can maybe, develop a group of with the anesthesiologist to figure out what kind of bundle can you offer to patients. So for example, in our hospital, we have non-pharmacological strategies such as distraction. So we use phones, iPads. Those are helpful as well. Those are helpful strategies to mitigate anxiety. Additionally, we do use a whole lot of sedatives. So things like midazolam, we give a lot of oral midazolam. We actually give sometimes IM ketamine for patients that will not swallow or will not take oral meds, or we do intranasal route as well. If they already have access, we also can give the sedatives via the port or central line, or IV if they are inpatient. So those are some strategies that we have. We also have Child Life, who's actually very helpful, especially if a kid is coming in and the patient is a frequent flyer. So if they come to the hospital often for different procedures, they may have built a strong relationship with our Child Life specialist. So we actually refer to our Child Life specialist quite a bit to help with these situations. So these are just some ideas and strategies of what we use in our pre-op.
We can also think of ways that we can promote comfort or managing anxiety depending on their age too. So like an adolescent might be a little bit different than a toddler. And again, just depending on what age is going to come to your hospital, thinking about that each age is going to be a little bit different. So if we kind of think of, I think most hospitals are taking on maybe the preschool and up age range. So thinking about that, these are times when they're starting to explore their own environment. They want their own autonomy. They're going to start asking questions. So really giving that time to answer their questions, to allow participation, and really avoiding those yes, no questions. Because sometimes if we ask the yes, no, like, can I do your blood pressure? if they say no, you're kind of stuck in a tough spot where it's, can I do your blood pressure on your right arm or your left arm? So giving them a sense of control, but really making sure that we get the tasks that we need to be done so that we can be as safe as possible. Again, this is not necessarily a complete list, but just looking at that each age group is going to be a little bit different. And this is also something that you can touch base on the pre-op phone call or the virtual visit to discuss any fears that they might have to start this conversation so that you can make it a little bit easier going in. Some strategies that you can also use, like Jess had mentioned, is having opportunities for play, using the child life if you have it. If your hospital doesn't have a child life specialist, we do have lots of resources on our Connected Care Resource Hub, which again, I'll share in the chat at the end, so you can take a look at all of those. Also thinking about relaxation and pain management strategies. So we can use different ways to prevent needle anxiety. Again, we have some resources online that I'll share with you in the chat as well. And then also, again, thinking from a patient and family-centered process, really including working with the whole family to minimize anxiety, because we know if the child's anxious, the family's probably going to be anxious, and then they can feed off of each other. So thinking about how we can minimize this as much as possible. So like Justin said, using some non-pharmacological techniques, play-based play, and some deep breathing, musical therapy. Sometimes it's also just changing position. So can you remove them from the immediate location? Can they be in an area where it's a little bit more calming? We know that sometimes being in a waiting room that's very packed can also be anxiety provoking. There's also been questions, for example, about having parental presence during induction. So we understand that that's not common practice at all facilities, and it might not be the appropriate goal for the patient or for the family caregiver. So for example, even here at SickKids, like that's not our baseline strategy. We look at it on a case-by-case basis of what can be done prior to, knowing that going into the OR might not be actually comforting for both the child or for the parent as well. So thinking about also telling the family from a post-op perspective, having them available as soon as the child as soon as they're in PACU or the most appropriate time. So encouraging them to be back at the appropriate location. So for example, if they've left to go get a coffee, to be back at the appropriate location so that they can be in the equivalent of whether it's your PACU or waiting room, wherever that is, so that they can visit with their child afterwards and then still get all the expectations of discharge teaching and all of that. From a sense of time, I'm going to leave this up just while we chat about it. But if you are thinking about considerations for a child with special needs, thinking about, again, from a pre-op perspective to a day procedure to intra-op and post-op, that there are a lot of things that you can consider, knowing that it might add an extra layer of even complexity or just extra time that's needed, and that's okay. But thinking, for example, there might be a way that you can decrease sensation. So they might require a private room, less noise. Can you adjust the volume on any equipment, both from a pre-op perspective or intra-op? Can you minimize the wait times in the waiting room or the pre-op areas as much as possible? And then really establishing a plan with the family caregiver for if agitation behavior start, what's the best way to redirect or to prevent them from getting more agitated? Again, because we want to have them in a good pre-op standpoint, knowing that pre-op anxiety can lead to complications post-op.
I just realized I never answered Tammy's question just about the monitoring piece. So Tammy, just to go back to your question about birth at pre-op, and if they should be placed on an O2 sat. So essentially in SickKids, we don't associate medications with necessarily a level of sedation, because any sedative in a large enough dose can put you into a deeper state of sedation. So essentially what we ask is that all staff members who are trained in sedation, essentially. So we have sedation trained staff here that attend a workshop. They can actually name what sedation level that patient's at. So if you've gotten midazolam and you are, or the patient is at minimal sedation where they're still, responding to kind of verbal and they're still awake and they're sitting up, we actually don't need to put them on a monitor as an example. But as they, let's say the OR got delayed and now the patient actually is starting to kind of go into a deeper sedation where they're falling into moderate, where they are getting a little sleepy, a little more drowsy, requiring more stimulation to wake them up, that's when we would start considering putting them on a monitor. So just as a quick overview of how we assess sedation, but it's really dependent on the provider to assess that sedation and making sure they know the appropriate level of monitoring required.
And also thinking if you give pre-op sedation, thinking about if the child is walking around or
falls risk
there's a falls risk. So do they need to be in a stroller? Does the family need to have a wheelchair accessible? Just so that if they're not staying in your immediate waiting room, what that looks like.
That's a great point. All of our kids that get sedation in pre-op are placed in a wheelchair automatically before it even takes any effect. And there's a lot of teaching that goes into with the family just to let them know now that they've gotten this medication, they can't walk on their own. So just being mindful of that and not letting them kind of walk off on their own. Okay, we're going to move on now to the post-anesthetic care. So just to highlight, really pre-op is all about making sure that the child is well enough to undergo their surgery that day, because even though they may have had a call, let's say a week before or 2 weeks before for their pre-anesthesia consult, if they show up and PO status is violated or they are unwell, they're sick, they're taking, they have a fever, etc., it's still possible for cancellation. So that's just that extra layer of assessment to make sure that the child is safe. Oh, there we go. Perfect. So we're now going to talk about post-anesthetic care. So this is in the PACU. So the child has undergone their operation. They've gone into their surgery and they're now coming out to PACU. So the first phase, PACU is actually broken down into several phases. So the first one we're going to talk about is phase 1. Phase 1 is the immediate post-anesthetic care. This really requires close monitoring. There's a huge focus on airway, breathing, and hemodynamic stability. I know Alicia pulled up that vital signs kind of just as a guideline, but for those of us working in PACU, we probably know that the hemodynamic stability looks quite different in phase 1. And so this is why it requires that close monitoring. Usually their blood pressure is lower, and they're very relaxed. There's might be more need to support their airway and breathing. So this is where you really have to focus in on that. In this phase, there's 2 nurses that are required to be on the same room or unit, meaning a nurse can't recover a patient alone in a phase 1 level of care. And the primary nurse or the covering nurse must have immediate access and direct line of sight when providing patient care during this phase. And as we talk about the complications, you'll understand why you kind of need 2 people there. So these are just some anatomical differences between pediatric and adult airways, and why when Alicia, covered the whole equipment and pediatric equipment, why it's so necessary. I hear the anesthesiologists talk about even the different airway equipment that they use, like the blades that they would use for pediatrics might be different than adults, etc. So just ensuring all of those things are in place. The anesthesiologists are involved with the kind of setup of the room, etc. Those are all important things. So we just have like a nice photo here where, pediatrics, they have a larger tongue in proportion to their mouth. Their pharynx is smaller. Their epiglottis is larger and floppier. So when they're sedated, that becomes a bit more of an issue. So oral airways come in handy. Larynx is more anterior than superior, and it's narrowest at the cricoid, and the trachea is narrow and less rigid. So these are all things that will affect how they intubate and things like that. So what are some common pediatric airway complications? So it's going to be a little bit of a longer slide. So the first one is a laryngospasm. So what is a laryngospasm? You can see here a nice photo visualization. That's a normal view of our larynx where air can just enter. But when a laryngospasm happens, it can be either partial or it can also be a complete obstruction where no air can enter at all. Oftentimes, this happens because the body thinks that it's a protective factor. They're trying to close the glottis to ensure that nothing enters in. However, it's actually causing issues because the patient's trying to breathe, but no air is able to enter in. What are some risk factors? There is a higher frequency in kids under the 5 years of age if they had a recent respiratory illness, if they have exposure to smoke, secondhand smoke, or they are a smoker, let's say with adolescents, if they have a reactive airway like asthma, and also the type of anesthetic used are actually can impact the incidence of laryngospasms. Frequent suctioning, because stimulation can also trigger a laryngospasm, or let's say they're coming out of their sedation and they're coming lighter, but they have their airway in, it could also trigger that laryngospasm to happen. It's often marked by, if you see a patient and they have a lot of increased abdominal and accessory muscle used, often you can see this. It's pretty clear. I don't usually even have to auscultate to see that this is going to happen. And there's always a delay when it comes to the SATs dropping. And so as soon as I see this with the patient, they sometimes start off with a cough. And then the abdominal or seesaw breathing, it might look like. It's important to look at and think of a laryngospasm because this requires help quickly because this can become a life-threatening event. And so what are some preventions that we can have? So you can place them in a recovery position so that secretions are not tickling their airway and causing a laryngospasm to happen. You can try to open their airway, so you can do a good jaw thrust or chin lift. You definitely call for help. This would require an anesthesiologist because you might need drugs like propofol or succinylcholine. You would apply CPAP with 100% oxygen. We use an MIE here, so we would hook that up to the wall and give them CPAP. And there's also a method where they can apply pressure on the laryngospasm notch, which is a lobule behind the ear. And sometimes when you do that strong enough, you can break a laryngospasm. So those are some ways to treat laryngospasm. The next one is bronchospasm. What's bronchospasm? Bronchospasm, so laryngospasm is upper airway, bronchospasm is lower airway. And this has to do with the spasmodic contraction of the smooth muscles of the bronchi. So in the lower areas, you can see the nice visualization here of how it looks when it's swollen, making it difficult to have air exchange. So what are some common risk factors? There are asthma. So again, reactive airway is a big one. A mucus plug, aspiration, allergies, or anaphylaxis, foreign body, or pulmonary edema. What are some signs and symptoms? It's characterized by wheezing, so you can often hear it through inspiratory or expiratory. You'll notice that there's a decrease in saturations typically. There might be an increased respiratory rate, increased work of breathing, like costal restrictions or mild dyspnea. So what are some nursing interventions? If they're more awake, at that point, you can try repositioning them to a more upright sitting position. If they're still sleeping, you could try a neck roll if that helps. Otherwise, you definitely want to administer bronchodilator. So if you start hearing the wheezing, you oftentimes the anesthesiologist will give Ventolin. And if this is in PACU, we'd often give it via nebulizer. And we would want to notify the anesthesiologist because this would be a complication from the anesthetic. So if it's something that developed later, or sometimes it develops intraoperatively and you notice it in PACU. Of course, you want to make sure that you provide oxygen if they are desatting. So that's something that we can support with, and supporting ventilation as needed. So if they are not breathing at the rate that they're supposed to, you can bag mask, give CPAP if it's severe, and there's a potential for reintubation, but we have not gotten there. So hopefully that doesn't happen. If you catch it early enough, prevention is key.
You have the waiting room.
Oh, yes. absolutely. Sorry. Yeah, perfect. Okay, and then the next one is aspiration. So aspiration is the inhalation of gastric contents. So this is why the NPO status is so important. And typically with some families, they tend to be creative in their answers, or when you're asking them, have they had anything solid? But they might think a banana is not solid because it's soft, and things like that. So really kind of teasing that out sometimes, or asking the child directly, like, oh, what did you have for breakfast today? You'd hope they say nothing. But this can happen. We've had patients come up to PACU and vomit right away. So just being ready to reposition them to sideline position, and always doing the safety checks at the bedside as well, to make sure that suction and things like that are ready. If needed, you'd have to maybe get an X-ray. So at this point, you're notifying the anesthesiologist, preparing for reintubation if needed as well. What are some risk factors? So if they have a depressed swallow reflex due to general anesthesia, they have a dislodged loose tooth, this can happen. Loose teeth is something we ask about in pre-op. Poor cough reflex. And yeah, we'll talk about post-op nausea vomiting, but really, anesthetics can trigger that vomiting, so it can happen in induction. The signs and symptoms would be coughing or just retching or vomiting right away. The next one is stridor. And stridor is a high-pitched sound on inspiration and or exhalation due to turbulent airflow through a narrowed airway. And this might be related to difficulty with the intubation. So now there's some swelling. So it could be from the tracheal edema. Or sometimes the procedure itself can cause this to happen, like bronchs and things like that. So signs and symptoms are crowing respiration. So they're high-pitched sounds, tachypnea, increased work of breathing, accessory muscle use. And what we would do is just administer oxygen, humidified air, elevate the head of the bed. We want to notify the anesthesiologist, and the common treatment through pharmacology would be a nebulized epinephrine. So we give that epinephrine through the nebulizer. And then if, with any of these complications, if the children were expected to go home, just to reconsider and watch them for a little longer, making sure that they're safe to go home without any monitoring before they get sent home. The last one is croup, and it's common in 1 to 4 years old. It can occur within 1 hour of extubation and up to 4 hours post. This can also be because of that traumatic intubation, subglottic edema, tight-fitting ET tube, and NP surgical procedures. Is that nasopharyngeal? Mm-hmm. And, yeah, and head or neck moving, coughing with ET tube in place. It's characterized by that, barky cough, and we would do very similar interventions, like elevating head of the bed, reassuring the parents, letting the anesthesiologist know, and as well as epinephrine. Perfect. And then I'm going to move on to the next slide. I see a question here, Chris. Thanks for these reviews. Laryngospasm is the most common post-op complication that we see in our PACU, especially with children under 5, and it also happened in the OR. More likely to occur in PACU. Yes, thanks for that, Chris. Chris is the educator at Michael Guerin, and she recovers pediatric patients as well. So it's good to share her experience. So just to highlight again, we talked about some scary postoperative complications, but they're all manageable, and it really does come down to the strategies to manipulate the airway and ensuring that their breathing is supported. Doing a good jaw thrust, and if they need we practice with our anesthesiologists for our new staff, so that's always helpful. Just gonna admit this person. Doing a good chin lift or sniffing position. We have some good positions here, like the chin lift, and side lying recovery position. If they can come out of the OR that way, that's even better. You can give CPAP, flow by oxygen, all these different ways to deliver oxygen, oral airway or nasopharyngeal airway if it's appropriate, or nasal trumpet, and a tracheal tube and an LMA if needed. Okay, and then pediatric emergence agitation and delirium. I hear there's a lot of questions on this topic, so feel free to ask questions on the chat. But this is all taken from the American Society of Peri-Anesthesia Nursing. So this is what emergence agitation delirium is. It's defined as a mental disturbance during the recovery from anesthesia. And it results in confusion, delusion, hallucinations. It's manifested, so you'll see these behaviors in the children: restlessness, involuntary physical activity, thrashing about in the bed, and moaning. This has been around for a long time. This phenomenon has been documented since the 1960s, and it's a very dissociative state of consciousness. The children look like they're often not aware that this is happening. It's more common to occur in children than it is in adults, and it's most likely to happen within the first 30 minutes post-anesthesia, so as they're first rolling into PACU, but it can also potentially be delayed for up to 45 minutes. So why is it important to treat this? Because there's different risks, not only to the patient, but also to the staff and the caregiver. So of course, when they're thrashing around, they can harm their surgical site. And the patient may fall because they are trying to get out of the stretcher and it's high, or the crib, or they're banging their head because they're so restless. So the staff and the caregiver are really trying to keep them safe. And this can also lead to harm to the staff and the caregiver. Anytime a patient is experiencing emergence delirium or agitation, this increases the demand on nursing staff. It often requires like 2-to-1 nursing, just to help at least in the initial phases until it's treated. Additionally, there's been a lot of articles that actually has shown that it can lead to maladaptive behavior. So if in the past the child was not bedwetting, they may, after a GA or after their surgery, go home and experience these things like bedwetting or night terrors and anxiety, and it can last up to a year. So we can see that the effects of pre-op anxiety can last from a short-term, medium-term, or even long-term. And it's you can actually see this in 50% of children after surgery. So it is quite a big problem, and it's important to address. There's also parental distress. It's really hard explaining to a parent, oh, this is normal, especially if this hasn't been discussed before. They see their kid or the patient lives it this way. And so we really try our best to kind of cover these topics, even in pre-op, just to set some expectations. Or if the child's actually exhibiting emergence agitation and delirium in PACU, and the parent hasn't been called in yet, we might try to treat it first with the anesthesiologist with either more propofol, dexmedetomidine, we'll get into that in a little bit, but with some drugs to see if we can reset and maybe their next wake up will be better. So what are some risk factors for emergence agitation and delirium? Preschoolers are at the highest risk, and it sounds like Alicia was saying that this is kind of the age group you might be taking. So just being mindful of that preschoolers are at the highest risk. Sometimes it could be related to postoperative pain. I have seen this happen, but it can also still occur in non-painful procedures as well. So sometimes I find as the child is kind of starting to wake from their anesthetic, we say like they're getting lighter from their anesthesia. If there's like a painful stimuli, let's say they had an eye procedure, but it wasn't treated with long-acting opioids, and they start to feel it, they start to get restless, and this can trigger the delirium or agitation. And we actually, I remember for one of the instances, we treated it with some pain medicines, and the child woke up like totally different the next time I tried. Anesthesia methods as well. So there's a higher risk of having emergence agitation and delirium with sevoflurane, which is our volatile gases. So if a child, if we did a pre-op history and we know that this child has a strong history of delirium, we may try to do total intravenous instead of giving inhalation. This might be something you want to think about, or the anesthesiologist would consider. Preoperative anxiety, if it's not been treated, and then the patient may wake up the same way they went down. So if they were not compliant with getting the mask induction, as an example, they may wake up with that fear of being held down for the mask. If the child is, this is a patient factor, if they're emotionally active, impulsive, and unsociable personality, then they just may wake up this way. We've also seen that. Rapid emergence from anesthesia, if they weren't ready to quite wake up yet and we started poking the bear a little too early, this can definitely happen. So that's why we often have a rule where we don't really start poking at our patients until about 25 minutes to 30 minutes from their anesthetic, just to see where they're at. But we start to wake them up just around that time. For surgical procedure, ENT and ophthalmology procedures, but there isn't very strong evidence, so just something to keep in the back of our minds, and history of problems with handling new situations. So there is a validated delirium pediatric scale. So it's called the Pediatric Anesthesia Emergence Delirium Scale. This is a validated tool that we are actually using at SickKids as well. And what it does is it measures the 5 physiological or 5 behaviors really that the child's exhibiting, which is, that they're making eye contact with the caregiver, their actions are purposeful. Are they aware of their surroundings? Are they restless, or are they inconsolable? And any score greater than 12 indicates that they have emergence agitation or delirium. Oftentimes when trying to treat delirium, the anesthesiologist might say, oh, I think they're just hungry, or they want their family, when the nurses know for sure this is likely emergence delirium. This helps with a higher level of objectivity versus subjectivity. If I think it's this, it's like, no, here's the score. We need to treat this above 12. So what are some treatment of emergence agitation? Like we said, the preoperative piece, helping with giving some, if they have pretty bad pre-op anxiety and they're having a hard time going to the operating room, giving them something like midazolam is very commonly used, and it's helpful for reducing pre-op anxiety. So this has been shown to be effective. And we want to also focus on reducing pre-op anxiety through anesthetic history of emergence agitation delirium. So getting that good history. Intraoperatively, we talked about the total IV anesthetic. So sometimes we can give midazolam where they're a bit sleepy. Once they get in, they can give laughing gas, sometimes nitrous, and start the IV, and then start giving the anesthetics like propofol through the IV. Dexmedetomidine is another drug that is been shown to be effective. It actually, the kids tend to sleep a little longer, but it's really good for treating emergence delirium. And this can be given at the end of the surgery. And fentanyl to treat the pain. Post-operatively, we do a good, thorough pain assessment and management, and we have to give opioids and adjuncts as needed. If they wake up and they're still having, any signs of delirium, the anesthesiologist may sometimes give another dose in PACU, or we can call them back and they can give either more dexmedetomidine, or sometimes propofol is still used as well. The next complication is postoperative nausea and vomiting. This is typically used to describe nausea or vomiting or retching in the post-anesthesia care unit in the immediate 24-hour post-op hours. Some risk factors are that surgeries lasting longer than 30 minutes. The older the child is, so over the age of 3, it's shown that there's a higher risk of post-op nausea vomiting. Females 11 years of older have higher risk of, or at the age of puberty. This might be linked to hormones. History of post-op nausea vomiting with a relative, or history of post-op nausea vomiting. Certain types of surgeries as well. There's not, again, this is not a super strong data, but some people think with strabismus, there's more data on strabismus, which is eye surgery. But the other ones are kind of, there's lots of different articles out there, but it's not strong enough to, I think, pinpoint it to say it's causal. If the child already has history of motion sickness, they may be more prone to having post-op nausea vomiting. Forcing PO fluids, so we let kids drink when they're ready, we don't force it. Even if they take nothing in PACU, we tell parents just continue to encourage them. Sometimes they're just not wanting to take something in this environment, but I encourage you to continue taking it and looking for signs of dehydration. Longer acting intraoperative or postoperative opioid administration as well can be higher risk of post-op nausea vomiting. I'm not going to go into the pathophysiology, but this is just to show that we have a vomiting center in the brain, and it can be triggered from multiple different things. So all the risk factors I mentioned before are kind of connected to these impulses, like the GI tract. So if you have a dental procedure or something like the patient was bleeding and they swallowed a lot of it, this can trigger nausea and vomiting through the vagal response. So just something to think about. If the child already has high anxiety, it could be adolescence as well. This can, anything they see, smell, they can just, and their emotions can cause that nausea, vomiting. We talked about the motion sickness. So if they have history of motion sickness, so if they have anything to do with their ear vestibular apparatus, this can trigger that vomiting center. And the last one is the chemoreceptor trigger zone. Just remember that anesthetics are also noxious stimuli. And so this can also be an increased cause of post-op nausea, vomiting. What are some preventative strategies for this? We have, if you know that there's a patient at high risk of post-op nausea, vomiting, it would be encouraged to do the total intravenous anesthesia, avoiding all volatile gases, no SIVO. So we'd start the IV in pre-op typically. Pharmacologic therapies are, the gold standard is to give ondansetron and dexamethasone intraoperatively. And then if needed, we can give Gravol in PACU. Just keep in mind with Gravol, it does cause some sedation as well. And so always looking at the benefits and the risks of giving more. Other therapeutic interventions are appropriate hydration through IV if needed, if they need a bolus, or intraoperatively, it's really important to give fluids as well. Additional use of O2 therapy if needed. We sometimes give the mask and say, do you want to take some deep breaths and some fresh air? And that helps as well. Pain management otherwise, so multimodal approach. So instead of just thinking only about opioids that can cause more nausea, vomiting, we think about, okay, have we given any ketorolac? Is there Tylenol that we can give? And in the intraoperatively, were there other things that they can do for pain, like local anesthetic or regional anesthesia? So those are some opioid-sparing strategies for effective postoperative pain control. And then, sorry. And non-pharmacologic interventions include, providing the O2. We talked about deep breathing. There's also evidence about acupressure. So acupuncture is using a needle, but acupressure is just that point and providing some pressure on there. There's some evidence around that, so you could always look into that. Consider aromatherapy if available. Lastly, we'll talk about discharge information, which is about how we make sure that our patient is safe to go home. So this is something that we use at SickKids for PACU. So we look at 7 physiological parameters, which look at conscious level and activity, respiratory stability, their oxygen saturation, hemodynamic stability, post-op pain, post-op nausea or vomiting, and the surgical and procedural site. When we switched over from moving from a time-based discharge criteria to the physiological scale, it was shown to reduce the length of stay without any harm. So that's why we actually move forward to this. And I think a lot of other PACU, pediatric PACUs, or just PACUs in general are moving to this as well. So really, it's important to have written and verbal discharge instructions. The child is discharged home with a caregiver. Discharge order is present from an anesthesiologist or a delegate, and physiologic discharge criteria is met. This scores out of 14, and any score greater than 12 can go home without an assign out from our anesthesiologist. If a child had severe pain, so we have post-op pain here and it needs to get IV analgesics, we do recommend that they have to stay 30 minutes on a continuous monitor just for additional monitoring to ensure that there's no apneas or desaturations, respiratory depression, etc. And then in regards to discharge teaching, we have all of this information, such as postoperative symptoms to watch for and who to contact. The postoperative complications are typically written by the surgeon. So the surgeon should be adding to the discharge papers as well. And it's typically what they've discussed already verbally with the parents and the patient. We have key contacts and phone numbers. Any diet, activity, or general restrictions would be important, like starting off with clear fluids, that they may be groggy for the first 6 hours. Teenagers shouldn't drive that day. Those kinds of things would be helpful. Dressing or wound care instructions, again, this can vary from surgeon to surgeon. So this is important for them to kind of be involved in this. And then medication instructions like continuing Tylenol and Advil, maybe around the clock. So this is a lot of coaching around pain meds. Lastly, follow-up. So this is usually determined again by the service and the surgeon, and we just relay this information that's often written.
And it can be really important. One last point is to have it, like you had mentioned, written and verbal, because we know that sometimes it's different than in adults. For example, there's more care that the parent will have to give for the child when they go home. It can sometimes what you tell them might go out one ear just because solely from just the stress and anxiety. They're taking care of their child when they go home, right? So let's set them up for success. Tell them everything for sure, and then give them something that they can read when they're at home and a little less anxious, and providing as much time while the child's like coming out of anesthetic to give this information, just so there's less distraction and more time for questions.
Sometimes we call them in at the 30-minute mark before we wake the child up. The parents at the bedside, we do the discharge teaching with them. And as we wake the child up, parents already there, discharge teaching is done.
Yeah.
So we have a little system. So that might be something to consider.
Made it just under time, so that's perfect. We have some time for questions. If anyone has any questions that they want to pop into the chat or unmute. We also ask for any feedback or evaluation after today. So if you wanted to scan the QR code on the screen, you can do that to then provide us with some feedback. Otherwise, we'll hang out for a few minutes for some questions as well. And then I'll get that link to put into the chat as well for you to be able to refer to for some different resources, as well as this webinar will be posted on our community hospitals website as well too, and we'll share it with our community partners as well. We have a question. When IV fluids is recommended for patients being, which IV fluids is recommended for patients being monitored in day surgery for a few hours? Is straight normal saline acceptable?
This is it may be patient dependent, to be honest with you, Tammy. So some our anesthesiologists like sometimes order ringers, but a common fluid that we use at SickKids is D5-9, so dextrose 5.9 in 0.9% saline. But normal saline, if it's only for a few hours, I think it's acceptable, especially if the child's going to be waking up and having something to drink quickly. I hope that helps.
Hi, it's Kamani.
Hello.
Question. Jessica.
Hi, Kamani.
Hi,
Is
Jessica.
that the Kamani I know?
Yes, it is. There's only one Kamani Abdul. But what I wanted to ask was, for your discharge instructions, I know that you're using that scoring system from discharge from PACU.
Yes.
But what if they're discharged from the inpatient peds unit? Like, for example, a TNA that's not going to stay overnight, that's going to go home early evening. What's your discharge criteria for them? Is it the same scoring system?
So you know the bedside pews, Kamani? Did they roll that out? Like, I know they rolled it out at Markham Stouffville a while back. That's what they use on the inpatient units, the bedside pew scoring.
Okay, so at SHN, Central Eastland, we don't have bedside pews because we have Epic. So Epic does have an early warning system, but we haven't incorporated it into peds.
You could look into that, Kamani, if you'd like. Otherwise, for TNA, I find that at SickKids, we're admitting the TNAs that are quite complex. So oftentimes they have like other complicated medical history. So they tend to be the outliers that stay longer than the usual ones that are done in the community. So it might not be as applicable. But if you can look into the early warning sign, I feel like if their score is low and all of those things are met, and there's a good discharge instruction and follow-up kind of strategy, then I think it would be safe to look into that as a discharge. I hope that helps.
Okay, thank you.
No problem.
Great questions. Does anyone have any other questions? I don't see any other ones in the chat. I popped that resource, the website in there for community hospitals, as well as the link to do an evaluation as well. We'll stay on for a couple more minutes in case there's any questions.
Hi guys, it's Chris.
Hi.